Get started. So today we have our penultimate seminar for this year, and we're excited to continue offering these seminars next semester as well. So keep an eye on your inbox for updates for future presenters and dates. I want to start off first by introducing to people who haven't had a chance to meet them, since I believe this is your first research seminar. Kyle Murphy.
Hey guys, how you doing? Nice to meet everybody.
You are, and then
Hi, Kyle.
Thank you.
Mhm.
and I think
Kyle is our new academic program coordinator, so we'll be seeing a lot of him going forward. And today we have two great presenters. I'll go ahead and introduce now. The first of which is Maggie Clapp, a graduate student in the Department of Psychology at the University of Texas. Her research uses multivariate longitudinal and genetic methods to understand individual differences in cognitive function and personality across the lifespan. Her dissertation work focuses on characterizing trajectories of cognitive decline and pathways of dementia risk in older adults. Today, she'll present her ongoing work identifying distinct pathways of risk for dementia, and will discuss their relevance for dementia prevention and treatment. Please welcome Maggie Clapp.
Hi, everyone. I guess I'll just share my screen and launch right into it. Um, Perfect. So today I'm talking about some of my dissertation work, which uses a joint growth survival model to look at distinct longitudinal pathways of genetic risk for dementia. Um, So many risk factors have been identified for dementia. For example, more years of education is quite well known as a protective factor for dementia. And then ApoE is a single genetic variant that confers a significant amount of risk for Alzheimer's disease. And it's one of the most replicated known risk factors for dementia. So even though there's this work that's establishing modifiable risk factors for Alzheimer's and for dementia more broadly, we need to understand at what point in the lifespan risk factors are affecting cognitive functions so that we can maximize the effectiveness of interventions to prevent or treat dementia. So part of what complicates identifying risk factor mechanisms is that dementia diagnosis is based on an implicit threshold. So clinicians will screen for very low cognitive function using tests like the mini mental state exam or the clinical dementia rating scale, which are shown here. But these types of measures don't capture the full spectrum of variation in cognitive function. So everyone cognitively declines with age, but that decline may or may not be severe enough to affect everyday tasks. And so to be diagnosed with dementia, we have this fuzzy or implicit threshold where cognitive decline needs to be severe enough that you're unable to do everyday tasks. And so when we have this threshold, there's two possible pathways for why someone hits that threshold. I'm going to illustrate these two pathways using these graphs where cognitive performance is on the y-axis, age is on the x-axis, and this big red dashed line represents the point at which cognitive performance is low enough that dementia is diagnosed. So I have three different levels of a risk factor here as well. Low risk is the line in green, medium in yellow, and then high is in red. So in this first example, we can see that everyone's pretty much the same during development, but during aging, different levels of risk have different rates of cognitive change. So we're seeing different slopes. In this case, the risk factor is affecting cognitive aging and causing differences in the rate of decline. And this is often the model we assume is happening when we think of a dementia risk factor. The other scenario, though, is where the risk factor affects cognitive development and then differences persist into adulthood. So in this case, the green line, the lowest risk, reaches this really high peak of cognitive function during development. And then even after decline begins, stays quite far from the threshold because that peak is so high. Whereas the red line starts much closer to the threshold and hits it more quickly once decline starts. So there's no differences in the rate of cognitive change in this case. There's only differences among these risk groups that are from pre-existing differences in development. So those differences then persist through adulthood, which causes differential rates of diagnosis among the groups. So the key aims of this project are to differentiate between these two longitudinal pathways of dementia risk, aging-related decline versus premorbid differences in cognitive function, and identify whether risk factors are associated with risk for dementia via aging-related decline or premorbid differences. And so I'm using data from the health and retirement study for this project. Some of the benefits of this sample are that we have a very large sample size. So just for genetic analyses, we have about 10,000 people, which is quite sizable. And then we have an age range from 50 to 103 at baseline. We've excluded anyone younger than 50. And then HRS measures participants every 2 years, and we have about 15 waves of data over a total of 27 years. So this is an enormous amount of longitudinal data. Some of the limitations of this sample are that we don't have a clinical assessment of dementia. We have these Lange-Weir scores, which are imputed dementia scores based on cognitive measurements. And then the cognitive testing is a little lower quality than maybe we'd like. So in this project, we focus on total cognition score, which sums the scores from all 7 cognitive tests in HRS to try to get a better picture of the cognitive ability of our participants. And then I'm not presenting this data today, but moving forward, we do plan to compare our HRS results with results from a more deeply phenotyped cohort with a smaller sample size, just to get sort of the full picture of what's happening here. So we're interested in looking at genetic factors. So I'm using genetic risk scores, which are polygenic indices or PGIs. And PGIs are essentially just a weighted sum of genetic effects on a trait. So for example, if we have 1,000 genetic variants that are all related to BMI, we estimate the size of the effect that each variant has on BMI, and then we create a score for each individual that sums up how many of those variants they have. And so one reason we use genetic scores is that these large epidemiological studies like HRS don't always have gold standard phenotypic measures. And so PGIs measure sustained genetic liability to a trait, which can be more stable than the observed trait. So for example, if somebody has a really high genetic propensity to BMI, it's possible that if we have only one measurement at a certain point in time, that measured BMI may not reflect the average BMI that that person has over the lifespan. And genetic scores do a little bit of a better job of this. And so the risk factors I'm going to be talking about today are sort of in 2 groups. We have these established risk factors that I talked about before, educational attainment, APOE, and then a suite of polygenic predictors, which are all genetic scores for these phenotypes. So we have a group of cognitive phenotypes like educational attainment, cognition, and then scores for Alzheimer's disease with and without APOE, some lifestyle and health factors like smoking, BMI, type 2 diabetes, and coronary artery disease, and then a psychiatric factor with genetic risk for schizophrenia. So in order to answer this question of whether risk factors operate via premorbid differences or age-related decline, we use this joint growth survival model. So there's a growth model on the bottom here where we have this factor of cognitive level and a factor of cognitive change. And then we regress 3 things on the external predictor, which could be the PGI, APOE, or whatever our predictor of interest is. And so the 3 things that we regress on that predictor are the level of cognitive performance, which is the pathway in blue, the change in cognitive performance, which is the red pathway, and then the log dementia hazard, which is the likelihood of dementia diagnosis in green. So there's 3 pathways that we're looking at using this model. The indirect effect on the hazard via cognitive level in blue, the indirect effect on the hazard via cognitive score change in red, and the direct effect of the predictor on the likelihood of dementia diagnosis in green. So first, I want to look at results for 2 well-known predictors of dementia, educational attainment and APOE, and we'll start with education. So on the left are the theoretical patterns of what we should see for a predictor operating through premorbid differences or aging-related decline. And these graphs on the right are growth curve slopes, where each panel is representing different values of the predictor. So for education, we're seeing sort of average scores for individuals with a college degree, a high school degree, and then individuals with no high school degree. And these lines represent the total cognition score across time. And then I have a gray dashed line representing the threshold for a diagnosis of mild cognitive impairment, and the black dashed line for dementia diagnosis. And so in these first group of blue graphs, we're holding the slopes constant. So the differences are only showing the effect of education on premorbid differences in cognitive function or differences in the intercept. And we can see that across these different levels of education, we're seeing significant differences in the intercept. That purple dashed line in the far right graphs is showing the average cognitive score for the group that has a college degree. So we can see there's a significant difference between people with a college degree, a high school degree, and no high school degree. Where as individuals have less years of education, their premorbid cognitive function is lower, and that causes them to hit the threshold a little earlier than those with a college degree. If we look at this next set of panels, here we're holding intercepts constant, so we're only looking at the effect of the predictor on aging-related decline, and in this case, there's much less difference across the three panels. So education's not really having an effect on the rate of decline. So importantly, this is showing that education is strongly protective against dementia, but not because it protects against cognitive decline or by slowing the rate of decline. It's rather that people have different starting points of cognitive function, and that's causing these differences in dementia risk. If we look at ApoE, it's basically the opposite story. So going back to these panels where we hold slopes constant, we can see that differences in the number of E4 alleles does not really have an effect on premorbid cognitive function. All of these lines are essentially starting at the same place. But then if we look at the effect of ApoE on aging-related decline, having two E4 alleles is clearly having a much steeper decline than having none. So as we would expect, ApoE does affect the rate of decline in aging. So if we look at the polygenic indices, here we're looking at all of them at once. So we're looking at hazard ratios, which index the risk of dementia diagnosis for each predictor. So this black line in the middle is a hazard ratio of 1. So a hazard ratio greater than 1 indicates higher risk, and then a hazard ratio below 1 indicates a reduction in risk. And then I have the hazard via premorbid differences is in blue, and then via aging-related decline is in red. And just for reference, the first two results on the left are years of education and ApoE, showing again that we see this significant protective effect for years of education via premorbid differences, and then a significant effect for ApoE via cognitive decline. And then if we look at the PGI for educational attainment, we can see that it's the same as the effect for education, where we see reduced dementia risk via premorbid differences. And so both of these results are indicating that education is protective against dementia, but that effect operates through developmental pathways earlier in life, not through preventing decline. For the cognition PGI, while we might expect only an effect on premorbid differences given our results for education, we actually see significant effects via premorbid differences and age-related decline. So many samples in the cognition GWAS that this score is based on have middle-aged and older adults that have probably already experienced some decline. So we see genetic signal that's a mix of developmental and aging processes. If we look at the Alzheimer's polygenic indices, the one on the left includes ApoE and on the right excludes ApoE. We can see they're quite similar, and they're both associated with increased dementia risk via premorbid differences and age-related decline. So this just underscores that Alzheimer's genetics are really a mix of developmental and aging processes. And if we compare that Alzheimer's score that has ApoE included to the ApoE result, we can see that when we include this noisy polygenic signal with ApoE, we sort of wash out ApoE's association with age-related decline. So Alzheimer's genetics are often assumed to be tapping biological pathways that are associated with cognitive decline, but really from both of these scores, we have a mix of the two pathways here. Moving into the health and lifestyle factors, we had no significant effects for type 2 diabetes on either pathway. The BMI PGI is significantly associated with increased dementia risk via premorbid differences and has no effect on age-related decline. No significant effects for coronary artery disease. And then the smoking PGI is significantly associated with increased dementia risk, but only via premorbid cognitive differences. And then probably the most interesting result to me, the schizophrenia PGI is associated with reduced dementia risk via premorbid differences, but increased dementia risk via aging-related decline. So we have this interesting antagonistic effect here where the premorbid association likely reflects links between genetic liability to schizophrenia and creativity and curiosity that can be related to higher education. And that aging-related decline effect probably has something to do with a shared genetic liability to neurodegeneration. So just in sum, dementia risk factors operate through these two distinct pathways, premorbid differences and aging-related decline. We often assume that correlates of dementia operate through degenerative processes, but that's not always the case. And so many of these associations that we find are not operating through decline, but through premorbid differences, which is different from the typical interpretation of how risk factors for dementia operate. And so these two distinct pathways have really important implications for interventions. For example, if we develop interventions that are applied to older adults, we need to make sure the factor we're targeting is something that's actually operating through decline and not through developmental or childhood pathways. And so using this growth survival model, we can identify risk factors that do have genuine associations with decline or neurodegeneration, so we can target our interventions more effectively. So that's all I have. I just want to acknowledge all my collaborators on this project and my funding. And thank you all for coming today.
Thanks, Maggie. Any questions for Maggie?
Yeah, this is Mark. Maggie, that's great. I really enjoyed your talk. We have a lot of complementary results to you as well using the HRS. And the other thing is, we've played this out like you've done in Korea, and it's the same pattern. It doesn't for education. It really doesn't. It doesn't seem to matter. And there's a recent paper that Yuan Zhang at Columbia published where she's showing the same basic association between cognition around the world in education. So it's one of those kind of social facts, if you will, that's so unusual that, because usually we think the effects of education are so contextualized, and they don't appear to be. So I'm fascinated by that. I thought I'd let you know about that.
Yeah.
The other question I have though is APOE and race. So, there's not a strong relationship between APOE4 and dementia risk among Black Americans, but there is among white Americans. So have you thought about that or worked that into your analysis?
I'm not super familiar with this research. Like I know of it. So we haven't broken out racial groups in this work at all. So we haven't really looked at that. I don't know if the sample size is really there for us to do analysis among different groups at this point.
Well, I will say that there's a paper in neurology, and I'll try to send it to you. And if you don't see it within a little while, bug me, will you? Because they have done the ancestry markers, and so they are defining groups that way, and they've been looking at the fact that there's no strong relationship between the APOE4 and the risk of dementia among Blacks. So it's a quite interesting story about the contextualization of APOE4 and how it's working. So anyway, I'll send you that paper.
Yeah, great. Thank you.
You're welcome. Great talk. I love that talk.
Excellent talk, Maggie. Thank you. If there aren't any other questions, we'll jump into our second presenter. So Dr. Heatlh Orsini is an assistant professor in the Department of Psychology and Neurology and a member of the Wagner Center for Alcohol and Addiction Research at UT Austin. She received her MS and PhD at the University of Michigan in biopsychology and then completed her postdoctoral work at the College of Medicine at the University of Florida. Dr. Orsini's research focuses on understanding the neurobiological and hormonal mechanisms underlying decision-making and how these processes can be compromised by substance use. Her work has been supported by NIH and focuses on the effects of opioids on decision-making and the neurobiological substrates of estradiol-mediated female risk-taking behavior. Dr. Orsini has published extensively on these and others, resulting in over 40 peer-reviewed publications and several book chapters. Please welcome Dr. Orsini.
Thank you. I want to make sure everyone can see my screen. It's like not presenter view, it's the actual, okay, cool. And everyone can hear me well. Great. So thank you for this invitation to talk about a little bit about the work that we're doing in my lab. My lab has been here at UT Austin for No, this is my 6th year, and so we've really established the research group that is interested in understanding the basis of behavior, in particular risk-taking behavior, and how the biological mechanisms that underlie this behavior may change after exposure to different drugs of abuse, so substance use disorder. So I'm gonna talk about just a kind of few different lines of work in the lab. So as we move through our daily life, we're constantly making decisions, and many of them are seemingly trivial. So, for example, should you take the elevator or take the stairs? Should you order regular coffee? Or maybe if it's in the afternoon, perhaps you should switch to decaf. Should you have dessert or maybe not? So these decisions, we make really quickly. We don't give them much thought. But there are other decisions that have outcomes that are much more consequential. And these decisions involve evaluating options that differ in their potential rewards and the associated risks of negative consequences that may accompany those rewards. So examples that may resonate with you include things like, should you respond to a text message while you're driving? Or what should you do when you approach a yellow light? And in the latter example, you may be, rushing to get somewhere and you approach a yellow light, and the more rewarding option obviously is to step on the gas. You can make it, you can get through, but it's also associated with potential risks. They vary in kind of their adversity. For example, it could be you get in a car accident, a ticket. The safer option is to stop and not move, but it's not as rewarding. And so these are decisions that hopefully we're all able to make effectively and adaptively in our current situation. But in a variety of psychiatric conditions, risk-taking or this risk-based decision-making is altered. And in particular, what we see in substance use disorder is that it's associated with elevated risk-taking. And this has been observed across various substances, so including alcohol, cocaine, opioids, methamphetamine. Others include nicotine, marijuana. So this is a common cognitive feature that we see in substance use disorder. We not only see it across various substances, but elevated risk-taking is observed during the actual use. So when individuals are dependent on these different drugs, but we also see it following abstinence. So once people are in recovery, what we have observed and what's reported in the literature is that this elevated risk-taking persists, and it can vary in length. From several weeks to many years. While drug taking itself is considered a risky behavior, what we also see in individuals with substance use disorder is they display elevated risk taking in behavior that's independent of the drugs itself. And so examples include engaging in risky sexual behavior. There's increased rates of criminal activity. Risky driving behavior, so texting while driving has actually been shown to be associated with greater alcohol use, gambling, assault. So it's not just, risk-related behavior that's specific to drug taking, but it kind of affects multiple aspects of an individual's life. And what we know is that this elevation in risk taking is because these individuals are hypersensitive to rewards. So they really, really like the rewards that come with drugs, but with that are associated with some of these riskier behaviors. But what we've started to see probably in the last 5 to 10 years is that it's also due to this hyposensitivity to risks. So they exhibit this blunted sensitivity to the possibility that something bad's going to happen. And this feature of this elevated risk taking is what my lab is particularly interested in, is really understanding what is driving or what is changing to lead to this hypersensitivity to risks. To begin to answer this question, we don't use humans. We actually use rodents. We use rats. We use a rat model of risk-based decision. So this is our risky decision-making task. And in this task, we put rats in a chamber, and we basically give them a choice between two levers. And if they, let me see if I can get a pointer options. Can you see hopefully you can see my laser pointer, but if they choose, they have a choice between a small lever or small reward and a large reward. If they choose this small reward, they press the lever, they receive one food pellet, nothing else happens. There's no punishment. But if they choose the other option, they will receive a larger food reward. But in addition, there's a risk of foot shock, and this risk of punishment or risk of foot shock will increase systematically across the test session, so that it increases in 25% increments. And what we see is something like the behavior that I'm showing you here on the left. So this is a figure that you'll see several times in this talk. We'll have on the x-axis, we'll have risk of punishment. And then on the y-axis, we have percent choice of the large risky reward. And as the risk of punishment increases across the session, rats will decrease their choice of the large risky reward. So we call this discounting behavior. And rats are very good at learning this task. It takes them maybe about a month or two to learn. And then we can ask a variety of questions, one of which is what happens when they are exposed to drugs. This has actually changed their decision-making behavior or risk-taking behavior, like it's been observed in humans. And so what we have actually found is that, yes, similar to what's been reported in cocaine users, there's this increase in risk-taking. So in this experiment, rats were trained in our decision-making task. And so you can see here again that you show this, there's this discounting behavior. And then we split our animals into two different groups. And one group they'll be implanted with a catheter directly into their jugular vein. And then they basically have the option to self-administer intravenous cocaine. So if they nose poke into this active nose poke here, they'll receive an intravenous infusion of cocaine. If they nose poke into this inactive hole, nothing happens. We also have control animals that are just given they undergo surgery, the same procedures, but rather than getting intravenous infusions of cocaine, they just have access to oral sucrose or sugary water. And what we find is that after animals go through cocaine or sucrose self-administration, we let them sit for a couple weeks in abstinence, and then we retest them in our decision-making task. And we see that only the animals with a history of cocaine self-administration display this elevation in risk-taking. And this is not only compared to their sucrose control counterparts, but to their behavior prior to self-administration. So this is, this lends translational validity to our model of risk-taking because it nicely corroborates what's been observed in cocaine users and cocaine users in abstinence. So based on this data, my lab has constructed this conceptual model and we hypothesize that over the course of drug use, we see there will be this gradual increase in risk-taking due to the impact of drugs on brain regions that are normally involved in decision-making, risk and reward evaluation. And when individuals enter abstinence, this because you don't have this drug on board, some of these changes in the brain are unmasked, and behaviorally this manifests as this elevation in risk-taking. And we hypothesize that this elevated risk-taking may put individuals at higher risk for relapse, which can then kind of start this cycle again. So we suggest that by intervening during this abstinence period to target elevated risk taking, perhaps we can kind of stop this cycle. We can mitigate the drug's effect on this risk taking and perhaps prevent relapse. Now, to be able to test this model, we really need to identify what are the underlying cognitive and biological mechanisms for risk taking in males and females before we even introduce drugs into the mix. And only then can we understand how these mechanisms become compromised after drug use. And so today, I'm going to tell you just about two different lines of work in the lab that are both employed to address this goal, but gives you a sense of kind of how we're approaching and testing our model. So the first is talking about kind of sex differences in risk taking. And then I'll end with talking about the work we've done with illicit drugs, in particular synthetic opioids, on risk taking. So until recently, most of what we know about the mechanisms that promote decision-making and risk-taking in particular is based on studies using male subjects. We know, however, that sex matters, and it matters for several different reasons that are really relevant for our research goals. So there, anecdotally and in the clinical literature, there are robust sex differences in decision-making, with males being predominantly more risk-seeking or risk-taking than females. There are also reproducible and robust sex differences in various aspects of so although the overall rate of drug use or recreational drug use is greater in males, what we tend to see in females is that once they've initiated use, there is a greater rate of progression of the disease of substance use disorder in females, and that they are at greater risk for relapse. And so to be able to really understand the mechanisms underlying risk taking and how it's related to substance use, we need to study both sexes. And what we now know about risk taking in this model that I've talked to you about is that there are indeed sex differences. So again, this is lending face validity to this model where we see that males are more risk-taking than females. And we see this across many groups of animals. So it's this really robust finding. And we've done a lot of work to show that these sex differences are not secondary to other behavioral differences between males and females. So it's not just because males are more motivated to work for food. It's not just because males are less sensitive to receiving a foot shock. It's also what we've seen in females, their behavior is not because they're just more variable, because they have fluctuating hormones. This is this is truly, and I have references here if you're interested in, but we've spent a lot of time really trying to characterize this behavioral effect to say that this is truly something about the way in which males and females differ in their evaluation of risks and rewards. And what we have begun to do in the lab is try to understand what are the mechanisms that are driving sex differences. And so we've done a lot of work in both males and females, but I wanted to highlight some of the work, the more recent work that my graduate student, Leah Truckenbrod, has done in the lab looking at ovarian hormones. And even though I told you that risk-taking in females doesn't fluctuate over the course of kind of hormonal cycles, what we have seen is that you do need ovarian hormones for phenotypical female behavior. And the way that Leah tested this was to train females in our task, and then she removed their ovaries, so the main source of ovarian hormones. And what we see is that once you remove the ovarian hormones and you retest them in this task, there is this increase in risk-taking behavior. So they begin to look a little bit more like males. And when we then give estradiol back, so we replace it, we can attenuate this effect. So these data are really interesting because they begin to identify the mechanisms that drive phenotypical risk aversion, and it's really due to these ovarian hormones. Other work that I'm not going to talk about here, but that I've done before, that I've done as a postdoc, has also shown that if you do a similar manipulation in males, so you orchiectomize them or castrate them, you essentially make them look more like females. So gonadal hormones in general are really important for this phenotypical sex differences. Now, why does this matter, particularly in the case if I'm talking to you about substance use disorder? Well, I told you briefly in the beginning that cocaine administration increases risk-taking. We see this in both males and females. And what we've also shown recently, and that's actually been shown by others, a few decades ago at this point, is that cocaine can disrupt the hormonal cyclicity, the normal regular cyclicity during cocaine use and after cocaine use. And this has been shown in human cocaine users as well as in non-human primates and rodents. And we've shown this in our lab, that this disruption in hormonal cyclicity appears during self-administration, it persists during abstinence, and then it continues to persist during periods of time in which we see this elevation in risk-taking. So one hypothesis that we're testing in the lab is that perhaps this dysregulation of hormonal cyclicity may actually contribute to elevations in risk-taking, at least in females. And then we can flip it around and say, can we target the hormonal system to actually rescue these effects? And the answer to that is maybe, perhaps. And the way we're kind of thinking about it is that, how can we intervene? And what we have also been doing is looking at what happens when we give hormonal contraceptives. So these are synthetic hormones that many women take. And what we see is that in intact females, if you give these hormonal contraceptives, you can actually reduce risk-taking or reduce preference for this large risky reward. And so one possibility is that these synthetic hormones, so these are already available, right? They are being used by women, by millions of women. Maybe they have the potential to improve cognition during abstinence. And so this is a future direction of the lab. Now, some other work that I wanted to highlight that we have in the lab is looking at the impact of illicit drugs on risk-taking. So I told you a little bit about cocaine, but what we're also funded and really interested in my lab is the effects of opioids on risk-taking behavior. And like cocaine, there is clinical evidence that risk-based decision-making is impaired in current opioid users as well as former opioid users. And in fact, these impairments persist well into long-term abstinence and actually last much longer than the effects of stimulants. There's been some really nice meta-analyses looking at kind of how long these deficits can persist across different classes of illicit drugs, and by far opioids lead to the longest lasting impairments, up to 2 to 3 years in opioid users. And there's also, so we've been interested in opioids in general, but my lab has been drawn to fentanyl in particular, this synthetic opioid, because there's been a dramatic rise in, and many of you probably have read about this in the news, There's been this dramatic rise in the use of synthetic opioid, and it's not, and what I mean by rise in synthetic opioid use of fentanyl, it's not just in the use of drugs that are adulterated by fentanyl, so people are ingesting it unintentionally. There's been an increase in the intentional and deliberate use of fentanyl. So there have been various qualitative studies that have been done in the last couple of years that have looked at have really asked individuals who are using fentanyl not for medical use or prescription use why they're using them or what the pattern of use is. And what they found is that intentional fentanyl users were more likely to believe that their overdose risk was low, that they were more likely to engage in drug practices that increased their fentanyl exposure. So if you read these papers, what was really interesting to us, to my lab, is that it really indicates that these individuals are underestimating their risk for overdose. They just think it may not happen to them. And to us, this really suggested that their ability to weigh costs and rewards were compromised. Now, these were qualitative studies, and they are really important. They guided some of the questions that we had, but they don't tell us anything about the causal effects. Does chronic exposure or does use of fentanyl really lead to changes in risk-taking behavior? So that's where animal models are really nice, because we can ask questions like, does fentanyl increase risk-taking during abstinence? And to address this question, one of my other graduate students trained animals in our decision-making task and then had animals self-administer. So very similar to how I described intravenous infusions of cocaine, we did the same thing with fentanyl. So they were able to voluntarily self-administer fentanyl intravenously, or there was a control group that had access to sucrose. They did this for 6 hours a day for 14 days. And then we let them sit for 3 weeks in this abstinence period. So, they're not, when we retest them, they're not on drug, they're fully abstinent. So we're really trying to understand, do we see this elevation or in this impairment in risk-taking during abstinence, like has been reported in opioid users. And so this is behavior prior to self-administration, where we have males and females that are either going to go and self-administer sucrose or fentanyl. And this is just showing you that prior to self-administration, there are no differences between these groups. When we test them after self-administration, after this abstinence period, we now see that there is an increase in risk-taking in both males and females, but only in animals that have this history of fentanyl exposure. So this is similar to what I showed you with cocaine, but it also is aligns with some of the data from the clinical field, showing that you have this long-lasting elevation in risk-taking or impairment in risk-taking. Now, ultimately, I've repeated this multiple times. We want to be able to attenuate effects of drugs on risk-taking. And one way we try to do this that also would get at maybe what are the mechanisms that are driving these changes is, can we use different drugs to reduce risk-taking in these fentanyl-exposed animals? And so we used a drug, somanerol. It is a drug that binds to dopamine D2 receptors. And we chose to do this because we knew that in drug-naive animals, when you target this receptor, you can reduce risk-taking. You can make animals much more risk-averse. So we went into this experiment saying, well, we know that this is a drug that effectively reduces risk-taking in drug-naive animals. Will it do the same thing in animals that have been exposed to fentanyl? And if it doesn't, it actually says something about potential changes as a consequence of fentanyl. So here in our sucrose animals, we see that at the highest dose, that sumanerol will reduce preference for this large risky reward. And what we see in our fentanyl animals is very similar effect, but actually we see it at both medium and high doses of sumanerol. And so we're replicating this now to make sure that, these dose-dependent effects persist. But what this tells us is that, we perhaps a way to mitigate the effects of fentanyl on risk-taking is by targeting D2 dopamine receptors. Now, there's a lot of work that still needs to be done. And what we are really interested in is trying to understand the neural mechanisms that are compromised by fentanyl that promote elevated risk taking. So this is the model that I introduced to you in the beginning. And so we're really trying to zoom in on this abstinence period and understand what the specific neural mechanisms are that promote elevated risk taking. And what we hypothesize is that circuits that are important for drug naive and normal risk taking become hypofunctional. They're not recruited as strongly due to chronic exposure to fentanyl. And so the way that we want to test this model is by basically restoring function in some of these circuits and cell populations to see if this actually reverts risk taking or makes it look more like our sucrose controls. And we can do this with pharmacology, which I just told you about, but we can also do this in a more circuit and cell specific way using techniques like optogenetics, which basically allows us to shine different wavelengths of light into different areas of the brain to kind of boost the signal there to see if it can actually restore function and then restore risk-taking behavior. So those are some of the goals of our future work. And before I take questions, I just wanted to acknowledge that this is a lot of the work that I told you, and there's a lot more that we do in the lab. It's really a team effort. So I have a fantastic group of graduate students and undergraduates and lab technicians that have been, with me for several years that contributed to the work that I was telling you about today. We also have a fantastic support system at the Animal Resource Center, so vets and vet techs that are instrumental in our ability to do the work that we do. I have lots of different collaborators, and then funding from the National Institute on Drug Abuse has really led to all of the work that I talked to you about today. And if you have any other questions or interested in the lab, feel free to use this QR code or reach out to me, and I'm happy to take any questions.
That was immensely fascinating, Caitlin. In the health behavior theories, we always talk about decisional balance and weighing the risk reward. And it's fascinating to see the biological component here because we always just kind of accept that males have riskier behaviors than females. So it was interesting to seeing this aspect put into it. So I really enjoyed that.
Oh, I'm glad you enjoyed it. It's always nice when there's no questions because it means that I've done a really good job and I've just covered everything.
You did do a good job, and you did cover everything.
Thank you.
Right.
Well,
Oh,
no, sorry, go ahead. So I was just going to thank everybody for joining us today, and thank Jay for hosting. And wanted to encourage everybody or remind everybody that we're also doing another one next week. So it's usually every other week, but this month, because of the holiday, we have them in consecutive weeks. So I'll send another email reminder out about that one. But thank you very much to everybody for participating today.
Thanks again.
Thank you.
Thank you.
Bye.